My dear students, in this video, I'm going to discuss some points on the next generation fluid resuscitation strategies. Now, the practice of fluid resuscitation has seen a sea change in the past decades, from the past decades till now, and more changes are anticipated in our light of better understanding of such diseases where fluid resuscitation is practiced. What was the earlier concept of ARDS was purely confined to the lungs. Now, with better understanding of the heart-lung interaction and also the peripheral tissues and on the glycocalyx concept in sepsis, so these successive the strategies have been modified. And because the strategies have been modified, the choice of fluid, the type of fluid, the the speed of resuscitation and the need for de-resuscitation has also been highlighted, and their practice has garnered support across the evidences which has gathered. So, if we look into what would shape the next generation fluid resuscitation strategies, and to think about it as of now towards the end of 2025, we need to look into how evidences have flowed and how we have gathered their bricks and bats. Let us look into this classic trial which was published in NEGM in 2022, where restriction of IV fluids in ICU patients in septic shock was was studied by this group of Mayhoff et al. And it was seen that in septic shock patients in ICU, when restrictive versus standard fluids after initial resuscitation was compared, the restrictive fluid group got almost 2 liters less over their ICU stays without producing any difference in the 90-day mortality and without any major safety signal. So this is very important. And a year later, when the Clover's trial was published in the same NEGM, and it was seen that the early phase of sepsis-induced hypotension in ED, where the restrictive arm had less fluid and early vasopressors, while the liberal arm received more fluid and delayed vasopressors, and there was no mortality difference overall. But restrictive strategy was feasible and safe, and it reduced the fluid balance. A year later, in 2024, when the advanced CKD, which was a post hoc of the Clover's trial, was reported in the advanced CKD with sepsis-induced hypotension, restrictive or vasopressor first strategy had lower 90-day mortality versus the liberal. And in also at almost around the same time, this meta-analysis also showed that restrictive strategies consistently reduced fluid balance by 2 to 3 liters over 72 hours with either neutral or favorable trends in organ function. Now, all these evidences have gathered over a period of time. So how is this next generation practice is shaping up? If we try to look through the whole of these evidences, we can see that there should be an initial bolus still of 20 to 30 mils per kg, which should be probably the maximum limit in sepsis. But what is to be noted is that the practice would be with far more skepticism about going higher without proper reassessment. Early epinephrine through good quality peripheral access is now considered acceptable in many centers, and this is supported by Clover's analysis and on by the newer data on peripheral vasopressor safety. Early de-resuscitation by aiming to produce a net negative balance once perfusion is adequate rather than a positive balance has also gained momentum after the demonstration of its safety. So the next generation resuscitation would probably think about a little fluid, a lot of NOR-AP, and aggressive reassessment. Coming to another important factor, which is going to probably see a lot of changes and a lot of and which is kind of gain more importance, is a dynamic individualized fluid responsiveness, where the passive leg raising, which is the first choice in most shock patients, and the studies have largely supported this. Once we elevate the legs 45-degree from flat trunk reclined, this shifts almost 300 ml of blood from the extremities to the heart, or in other words, there is autotransfusion. And following autotransfusion, if we measure the cardiac output or stroke volume or the VTI and see a change of more than 10 to 15%, we give an additional bolus of 250 to 500 ml. If it is less than 10%, then we either start or escalate the vasopressors. If the patient is ventilated and sedated, we can go for pulse pressure variation, stroke volume variation. And if the pulse pressure variation is more than 13% or stroke volume variation more than 12%, the patient is likely to be fluid responsive. But one must know the limitations, that patient must, it must be fully passive, that ideal volume should be, it is more than 8 mils per kg, and it is not reliable in the presence of atrial fibrillation, uh, spontaneous breaths, and RV failure. In mini fluid challenge, one can give 100 to 150 ml over 1 to 2 minutes. And if the stroke volume increases by more than 5%, one can proceed with a full 250 or 500 ml of bolus. Likewise, end expiratory occlusion test with 15 to 30 seconds occlusion improves the venous return. And if the stroke volume of cardiac output increases by more than 5%, then one can ascertain fluid responsiveness. So this dynamic individualized fluid responsiveness is also going to shape the fluid administration in the coming days. The POCUS, which was earlier considered to be a luxury, is no longer optional, but it is the core resuscitation tool. And if you look into the eco target with the VTI increasing to more than 10 to 15% after PLR, we need to give fluids. If it is a small LV cavity plus low VTI of less than 50% along with collapsible IVC, the patient is likely to be fluid responsive. But if on echo the findings are of a dilated IVC with high CVP of 10 to 12 with venous congestion, then one should avoid fluids and instead consider diuresis. If there is RV dilatation with septal D-shaped, fluid may worsen the shock and one has to go for NOR-AP or inotropes instead. In patients with hyperdynamic LV and vasoplasia, small bolus may be okay, but early norepinephrine is crucial. So if the patient is not fluid responsive, we have to stop fluids. There are some red flags of harm between ongoing fluid resuscitation in patients who are not responsive, that is new or worsening hypoxemia or V lines on the lung ultrasound, rising CVV or Vexus grade of 2 to 3, hepatic or portal vein systole flow reversal, systolic flow reversal. It is though not a standard practice, but may become a standard over time. Low pulse pressure variation, stroke volume variation, and PLR negative. No change in VTI or stroke volume after 150 ml of bolus, and in the presence of peripheral edema and oliguria despite fluids. So one has to remember, and one will remember, that fluids will only help if the pump, that is the heart, can use them. One has to be also careful in recognize the two different things, the fluid responsiveness and fluid tolerance because they are not synonymous and they cannot be used interchangeably. So the question is that will cardiac output improve with fluid? If it is yes, the patient is fluid responsive. But can the patient tolerate the extra volume? If the answer is yes, the patient is fluid tolerant, but not necessarily the patient who will improve the cardiac output response to a fluid will always tolerate this extra volume. This fluid may accumulate in their lungs. The fluid may give rise to edema, the failure of the kidneys, etc. For example, in ARDS with RV dysfunction, the patients may be fluid responsive, but not fluid tolerant. So in such cases, vasopressors with or without inotropes should be preferred. We also have to think about frequent stop points, which means that after each 250 to 500 ml of bolus, we have to reassess and ask, is the MAP better? What is the lactate trend? Is it reducing? What is the capillary refill, mental status, and the urine output? And any red flags of fluid harm that I showed in the previous slide, like oxygen requirement increasing to B lines on the lung ultrasound by portal flow or JVP flow changes and congested venous Doppler should all make us aware, careful, and stop the fluids. So individualized hemodynamic guided resuscitation is what seems to be taking precedence in the coming days. If we look into some of those trials which compared the balanced salt and the normal saline, especially the SALT ED trial, the SMART trial, the sepsis subgroup analysis from the SMART and similar RCTs found that balanced crystalloids versus saline was associated with lower 30-day mortality and less AKI in sepsis patients. Balanced crystalloid for most resuscitation in sepsis and ICU is being followed, whether it is ringer lactate or plasmolite as against normal saline. And 0.9% normal saline is reserved for specific situations such as hyponatremia, traumatic brain injury, hypochloremic alkalosis, etc., based upon the local practice. Again, if we look into the method of restrictive and de-resuscitation as a full strategy, we have seen that there has been a sea change from what was practiced 2 decades ago. The classic trial, the post hoc analysis of other ICU trials have showed that restrictive fluid therapy doesn't delay lactate clearance or shock resolution, but reduces the net fluid balance. So it is always good to keep the patient's net fluid balance proper, that is, not to make it too much positive. So de-resuscitation through diuretics, early RRT, conservative maintenance fluid is increasingly protocolized in ICUs once the vasopressor dose is low or stable, lactate and SCVO2 if being monitored are acceptable, and there is no obvious ongoing shock state. So the time of shock is being viewed across 4 phases. One is the resuscitation, where we give small test boluses with or without NOR-AP. Optimization, where dynamic testing and fine-tuning of fluids and vasopressors and inotropes are taking place. Stabilization, where minimizing the maintenance fluids and also reducing or stopping the boluses altogether is practiced or followed. And the de-resuscitation phase, where active fluid removal in the form of diuretics, RRT, or ultrafiltration when congested is practiced. No, so now this distinction will be the key to the administration of fluid in the next generation. And so we feel that as we walk along the fluid administration process, one will be very careful, and one can see very clearly that in which phase the patient is currently passing through. So this is also a horizon along which the fluid resuscitation strategies are being guided along. Now, this is something new, and although enough trials are not there, but some positive trials is showing the way, and who knows that maybe there can be more positive trials coming up in the future on small volume or designer fluids like hypertonic saline to 7.2 to 7.5% with or without colloid or oxygen carriers. Even small volumes to the tune of 4 mils per kg can rapidly restores the map in animal hemorrhagic models and some trauma data. So most of the work with such kind of fluids is on the in patients with hemorrhagic shock. Likewise, hemoglobin-based oxygen carriers, HbOc201 and other newer molecules, while expanding volume, allow low-volume resuscitation and permissive hypotension. There has been work which has been supported through the animal and early human works, which showed improved tissue oxygenation and short-term survival, in particularly in the category of patients with the hemorrhagic shock. Again, the newer agents like VS101, which is also a HbOc solution, they have gathered preclinical data, which is reasonably good, suggesting that effective low volume resuscitation in hemorrhagic shock can be achieved with good hemodynamics by using such designer or low volume fluids. So, although no routine clinical tools have not confirmed this, but yet they may define the true next generation horizon. Now, another important aspect which is shaping up is the tailored resuscitation based on the shock phenotype and comorbidities. We know now that the shock phenotype is as important because of the no one size fits all approach being adopted far and wide. So, in vasoplegic sepsis with preserved cardiac function, one needs to be very cautious with the fluids, start early on high NOR-EP, consider adjuncts such as vasopressin, angiotensin 2 if available, etc. In septic cardiomyopathy or in mixed shock, one should limit crystalloids, add inotropes early, and use echo frequently. In advanced CKD or dialysis patients with sepsis, one should follow the Clover's subgroup analysis in CKD, where restrictive or vasopressor first strategy may actually improve survival as against the liver fluids. And fourthly, in ARDS or severe lung injury, very tight fluid balance and early deresuscitation should be practiced. So if we look into the next generation approach, what might be and what is the traditional approach, we can see a lot of changes, and probably these changes are like never before seen. In the initial sepsis bolus, the traditional approach recommends 30 ml per kg of fluid for everyone. The next generation may see 10 to 30 ml per kg, which can be quickly individualized. After initial bolus, the traditional approach recommends more fluids until the target map of 65 is achieved. In the next generation approach, it is the early NOR-EP and the dynamic fluid tests which try to achieve that target. The fluid type is normal saline by default in the traditional approach, and it is balanced crystalloids by default in the next generation approach. The targets of MAP65, the cervix of central venous pressure during output, are important in the traditional approach because the upstream parameters finally regulated the fluid administrations. But here, MAP along with microvascular circulation and organ perfusion are the targets for fluid resuscitation. Monitoring is based on static numbers in the traditional approach, where it is based on dynamic parameters like echo, passive leg raising, PPV, lactate trends, and the capillary refill time in the next generation approach, which is shaping up. The fluid balance by 72 hours is often 4 to 6 liters in traditional approach, which has been definitely can be harmful as reported from the literature. And the aim for neutral or negative if stable as per the next generation approach about fluid balance. But if stable, then what one can think about permissive hypotension and blood first research. In hemorrhagic shock, there is administration of large volumes of crystalloids by the traditional approach, while in the next generation approach, it moves from the crystalloids towards high hemoglobin oxygen carriers, hypertonic small volume resuscitation fluids, etc. So my take-home message would be that the next generation fluid resuscitation is shaping across the lines of these 6 key strategies. That is, start small, 1 or 2 targeted boluses while simultaneously starting early NOD-AP if the patient is hypotensive. Reassess after every 250 to 500 ml with dynamic tools such as the PLR, ECO, CRT, and the lactate. Use balanced crystalloids unless there is a clear reason not to use them. Avoid ongoing stealth fluids such as drug diluents, feeds, maintenance, etc. once the shock is stabilizing. Plan de-resuscitation early in ARDS, AKI, HF, heart failure, and the CKD once perfusion is acceptable. And always keep an eye on the horizon because HBOCs and small volume hypertonic strategies are, when being used, can give variable results. So thank you very much.